But why don't I start with introducing our grand round speaker today, everyone. Thank you for joining us. Rich is not available this morning, so he asked me to present. And I'm more than happy to because Matt Anderson is our fellow in endovascular neurosurgery. He is he has a very interesting background because he is an identical twin. And so we're dying to meet his twin one day, hopefully at graduation, maybe. But it's hard to believe there's two of Matt out there in the world, which is twice as good. So he went to Stanford for undergrad, graduated with a bachelor's in biology. He hails from Indiana, by the way, and you wouldn't know it with his cosmopolitan, persona, but he's a good old fashioned Midwesterner at heart, which is great, and you can tell because he's got that demeanor. And then he went to medical school at University of Connecticut and continued with neurosurgical training at Brown, where Zio Gokazlan has said incredible things about him. And he's got great experience with a lot of the work he's going to talk about today in endovascular and particularly carotid stenosis disease treatments. And his extracurricular interests in neurosurgery have included a significant amount of work in the DEI space. And I'm proud to say that one of our endowed professorships helped sponsor him to go to the CNS last fall as a representative for his program in the DEI committee of the CNS. So, and needless to say, Matt's been working extremely hard this year. I think he's really seeing a different way of neurosurgery practice and neuroendovascular practice, and we're really pleased to have him on our team this year. And it's hard to believe that it's more than halfway over already. But let's see. You can see that he's going to be speaking about carotid revascularization with a futuristic twist to it, with the next gen treatments that many of you may not even have heard of yet outside of the endovascular space. And Matt, thank you for speaking today. We really look forward to hearing from your experience with TCAR and other things. And again, thanks for a great year in progress.
All right, thank you for that introduction. As Dr. Kim said, I'll be talking about the history of carotid vascularization. Okay, of course, this is, I have no disclosures. So a bit about me. I actually have a twin sister, and she is now a PhD in clinical psychology and works at Dallas Children's. But we used to dress up very similarly for Halloween. So this is one of our clown costumes that my aunt made. This is my mom and my grandmother, and my dad is probably taking the picture. As you can see, I'm very confused on what's going on, and my sister's telling me to look at the camera. So the problem, stroke incidence accounts for 795,000 people per year, and it's the fifth most leading cause of death in the US. The average healthcare cost of stroke per person is estimated to be about $140,048 in the US. Carotid artery stenosis has a prevalence of 3% per year, or 3% in the general population, and 15% of ischemic strokes are attributed to carotid artery stenosis. And each year, about 100,000 carotid revascularization procedures are done. So the early days, when people were trying to figure out what was going on, in about 400 BC, the Greeks came up with the term keros, which spawned the word carotid, and it means to stupefy. This is a depiction of a centaur compressing the carotid of a Lapith warrior in the Parthenon. Hippocrates at the same time was doing a lot of postulating about the carotid and sudden onset paralysis and aphasia. which he thought was caused by apoplexy of the brain. He then went on to explain what we now know as TIA, as unaccustomed attacks of numbness and anesthesia, which may predict oncoming apoplexy. And then Rufus, circus 100 AD, explained that the term Keros was given because of the compression of the arteries that cause stupefaction. This is Claudius Galen, better known for the vein. But he also added to the body of work on carotid disease and noted that arterial occlusion was a cause of apoplexy of the brain. And he wrote about this in 130 AD. Then there's about a 1500-year gap, and a Swiss pathologist named Johann Wepfer in 1658 reported 4 cases of apoplexy of the brain, which he attributed to occlusion of the carotid artery. He wasn't clear of the etiology, as the significance of the atherosclerosis had not yet been explained. But then in 1664, Dr. Thomas Willis explained his work in cerebral anatomy, the 2 patients that were asymptomatic from right carotid artery occlusion. And he thought that they were asymptomatic because of their collateral circulation. In that same work, he talked about he introduced the circle of Willis and coined the term neurology, or doctrine of nerves. In 1754, the hypothesis of emboli arising from the artery was put forward by Dr. Van Swieten. He was also instrumental in dispelling the myth of vampires. So he did a lot of work in different areas. Virchow was in 1856 published his seminal work in which he coined the term thrombosis, ischemic, and embolus, and described that an embolus within the carotid artery was associated with ipsilateral monocular blindness. So we're just continuing to learn more and more about the carotid with these different physicians. In 1905, Hans Chiari, better known for his work with Chiari malformation, published his work on the thromboembolic hypothesis, in which he studied ulcerated plaques and surface thrombus, and his findings were the first to show that atherosclerotic plaque could cause cerebral embolus. And then Dr. Hunt then identified that both occlusion and stenotic lesions could be responsible for stroke symptoms. In 1927, Dr. Moniz performed the first direct cerebral angiogram via a direct carotid injection in 1927. And he then in 1937 was able to detail a few cases in which extracranial carotid disease was implied in cerebral pathology. And so we're continuing to learn about how the carotid is leading to these strokes. Interestingly enough, while he invented the angiogram, he was never awarded the Nobel Prize for it, but he was awarded the Nobel Prize for his work with frontal leucotomy. So the question then became, as we continue to learn about this disease, how should we fix the problem? Okay, so the first, the picture in A shows that there's a carotid plaque in the ICA, and B shows DeBakey's carotid endarterectomy, which he popularized. But he was actually not the first person to try to revascularize the carotid. C shows Dr. Eastcott's version of carotid revascularization, which he was actually the first person to write about this in 1954. He cut out the portion of the carotid that was diseased, and then he did an end-to-end anastomosis. There was also a group that cut the carotid at the disease segment and did this they did an eversion technique in which they everted the carotid, took out the plaque, and then did an end-to-end anastomosis. And then D just shows the patch that was also done by Dr. DeBakey when he sometimes had to do his procedures. So this is kind of our modern day carotid endarterectomy, where you do an exposure of the internal carotid, common carotid, and external carotid. You'll do your arteriotomy, take out the plaque, and then you'll sew up the arteriotomy either primarily, or you will sew it up with a patch. If there are EEG changes or SSCP changes, then shunting is employed. The picture on the left shows kind of a more one of the original shunts, which was an extraluminal shunt, and then the picture on the right is our endoluminal shunt that we employ today. Then in 1974, carotid angioplasty and stenting started to become more in favor. So in 1974, Gruenzig and Haupt introduced a balloon catheter for which there were percutaneous, they did percutaneous transluminal angioplasty. Then in 1977, the first ICA percutaneous angioplasty by Matthias was done for a patient with fibromuscular dysplasia. In 1980, Moulin described a percutaneous angioplasty for web-like stenosis, and in 1983, multiple groups reported successful percutaneous angioplasty for atherosclerotic disease. In 87, a balloon-type distal protection device was introduced by Therian, and then finally, the first carotid stent was placed in 1989 by Matthias's group again. And so I'll kind of go into, I'll show you some of the pictures of that in coming slides. So very shortly, our peripheral stents are done via, the access is gained via the radial artery or the femoral artery. And this is just a graph showing that the patients that undergo radial artery carotid stenting actually have a shorter length of stay in the hospital than our patients that have femoral artery access for their stents. And sometimes you're not able to do the radial artery stent because either the radial artery is occluded or it spasms down, and so you have to do it via the femoral approach. But the radial approach has been gaining more in favor. In A, this is kind of the evolution of the angioplasty and stent. So after we've gotten access, we then navigate the arch, and then we go into the carotid artery. Initially, these procedures were done without embolic protection, and as you can see in A, this is an angioplasty, and you can see all the debris that's going to the brain. Sometimes these infarcts can be silent, or they can be, cause a major disabling stroke. And so as people became more, understood this more, they developed a distal protection balloon to prevent the debris from going into the head. And then this is just and C is showing a stent that is being deployed with distal protection, the distal protection balloon. And finally, in D, this is our more modern day basket-like distal protection that we employ today. In E, we see that this is actually some of the first flow reversal that is seen, that is completed. And so you have a proximal protection balloon in the common carotid. So when you put that up, then you have flow arrest from antegrade flow. Then you have a protection balloon in the external carotid, and then through the sheath, there's actually flow reversal. And so people have been thinking about flow reversal for a long time, but hadn't necessarily been able to perfect it until now. So flow reversal. So in 2006, Andreescu showed that that he was having really great results with a procedure called TCAR, which is transcarotid artery revascularization. In TCAR, you do a 2 to 3 centimeter incision above the clavicle. It's a transverse incision. You expose the common carotid artery, and then you place an 8 French sheath into the common carotid artery. At the same time, you get access into the common femoral vein, and then you connect both sheaths to an extracorporeal device, which allows for flow reversal. In the device, there's a stop button, and I'll show you why that's important in a coming slide, but that helps you to confirm that you have flow reversal. And also inside of this device is a collection tubes, kind of like a siphon that collects all of the debris from the angioplasty and the stenting that you do because it's going it's going retrograde. So this is just another depiction. You see that there is, this is your clamp on your common carotid artery. So after you've done your cut down, you put a clamp around your carotid artery and you clamp that down once you're ready to do flow reversal, and you allow for flow reversal. When you are doing, and then you'll perform an angiogram in which you have your hand on the stop button so that you can stop the retrograde flow, and you confirm that it's going antegrade, and then you let go of the stop button and you confirm that it's going retrograde. And that allows you to know that you have flow reversal. From there, you do your angioplasty, your stent, and then you do a post angioplasty just to make sure that the stent is well opposed, and then you'll take everything out. There's a purse string that you'll put in around the site that you access, and then you close that up primarily. I tried to get some pictures, but I was not able to find any. So if people want to see pictures, I'll try to find some and send them to them later. So this is our angiogram, where we first show that there is antegrade flow, and then we let go of the stop button, and then there's retrograde flow. So as you can see there, when we have our hand on our stop button, it's going antegrade, and then we let go, and now it's going retrograde. And so now we know that we have distal protection with that retrograde flow. And then this is a video of just some of the clot that we get back in our device. So we do see a lot, and it's nice to see that it goes into that sheath and not into the head. That is what that looks like. So the requirements for TCAR, you want the lesion to be 5 centimeters from the clavicle. You want the vessel diameter to be at least 5 millimeters, and that's just because the sheath is 8 French, and you want to make sure that the artery is big enough to fit the sheath. You want there to be a lack of significant plaque at the access site, and that's because when you're introducing the sheath, you don't want to introduce clot or plaque before you have flow reversal. You want the depth preferably to be less than 6 centimeters from the skin, no active thrombus, and then you want there to be less than 3 millimeters of thickness for the calcium in the lesion. And that's because there's only so much radial force that you have with your stent. And so when you're putting your stent in, there's only so much that it can do. So if there is more than 3 millimeters of thickness, then this probably would not be a great procedure for your patient. So now we get into the data. This is a summary of some of the trials that have been done for carotid revascularization, and this is in no way meant to be an exhaustive list, but these are some of the more prominent and major trials that have been done. Symptomatic trials are NASCET, the European trials, and then the VA symptomatic trial, and SPACE and CREST. And then the asymptomatic trial is ACAS, ACST, VA trial, ACT1, and then CREST has also looked at asymptomatic disease as well. So in NASCET, there were three groups that were studied. The low to moderate, which was less than 50% stenosis, high moderate, which was 50 to 69% stenosis, and then greater than 70%, which was 70 to 99%, which was severe stenosis. And this was carotid endarterectomy versus best medical therapy. It showed that carotid endarterectomy reduced the 5-year risk of stroke or death by 29% in patients with symptomatic 50 to 69% stenosis. And it's important to note that the patients with greater than 70% stenosis, there was such a great benefit from this procedure that they actually stopped the trial early for these patients and just referred them for carotid endarterectomy. The other thing to note about this trial is that the best medical therapy at the time, only 70% of the patients got antihypertensives. Less than 70% of patients were placed on lipid-lowering agents or ACE inhibitors. And as we know, dual antiplatelets and aggressive blood pressure management and hydrostatins and all of those things are things that we do now that were not done in this trial. The other symptomatic trials, however, did confirm that greater than 70% with greater than 70% stenosis, patients had a benefit from a carotid endarterectomy. The other thing to consider when thinking about NASCET is the exclusion criteria. And so some of these were intracranial lesions that were worse than could be surgically accessible. Kidney, liver, or lung failure, cancer judged to reduce the life expectancy to less than 5 years, an infarct that deprives a patient of useful function in that territory, and then cardiac valvular disease. Temporary eligibility for this trial included uncontrolled diabetes, hypertension, and angina, MI in the past 6 months, signs of progressive neurologic dysfunction, contralateral CEA, and then major surgery. And it's important to note that when we're, kind of counseling our patients so that we know who does benefit and, what the data does actually show. And in the trial, the symptomatic was judged as non-disabling stroke, a TIA, a retinal artery occlusion, or amaurosis fugax. So those are the things that were seen as symptomatic. Asymptomatic disease is a little more controversial. There have been multiple studies that have shown benefit of CEA, the ACAST, ACST, and VA trials, but it's just a smaller percentage. So CEA to reduce the risk of stroke by 1% per year, and the number needed to treat was 33. So it was reasonable if the life expectancy was greater than 5 years and the perioperative risk was less than 3%. What's important to note is that the medical therapy for these trials were kind of all over the place. For the VA trial, they gave, the medical therapy was aspirin 650 BID, or if you couldn't tolerate that, it was 325 a day. For the ACST, it was aspirin plus best medical therapy, and then for ACAST, there actually was not a standardized medical therapy for that group. And so it's when looking at that, especially with asymptomatic disease, it's important to look at and see what these were really being compared to. CREST is another trial that was looking at whether or not carotid endarterectomy or carotid stenting was better. They looked at both symptomatic and asymptomatic disease, and it showed that that patients with carotid endarterectomy, patients that were greater than 70 tended to have a better outcome with carotid endarterectomy, and patients that were less than 70 had a better outcome with stenting. But stroke and death was higher in the carotid stenting group, and MI was higher in the the carotid group. And so when looking at patients and kind of looking at their profile, that's something to understand about this trial. The SPACE trial was another one that looked to see whether or not carotid stenting or a carotid endarterectomy was better. And it showed that there was no difference between the groups, but there was a difference in the amount of carotid stenosis after procedures. So there was a higher recurrent carotid stenosis in patients that underwent carotid stenting of 10.7% versus patients that underwent CEA. And actually, when looking at, there's a SPACE 2 trial, which I didn't put in the slides, but it showed that carotid endarterectomy and carotid stenting plus best medical therapy had similar results to best medical therapy alone. And that's why, but that was only for asymptomatic disease. So with the advancements in our medical knowledge, asymptomatic disease, we may need to look into who we are treating, and because there are still patients that would benefit from carotid revascularization, but they are usually the patients that have high risk features such as ulcerated plaque and things like that, worsening disease on serial imaging. The pooled data shows again that CEA showed an absolute risk reduction of 16% over 5 years, and the number needed to treat was only 6 in patients with symptomatic severe stenosis. Older patients when looking at the pooled data had a higher stroke rate reduction of 19.6% than younger patients, of 5.6% in patients with 50 to 99% stenosis. And so patients that are older, while sometimes we look at what is their 5-year lifespan and things like that, they actually tend to have a better result. If they have a higher stroke risk reduction than the patients that are younger. So we shouldn't necessarily exclude them solely because of age. The Roadster trial is the TCAR trial, and it's the prospective single arm trial, kind of showing the safety and efficacy of TCAR. And it was a group of, I believe, 53 patients, in which were mostly asymptomatic, though there were a few symptomatic that were greater than 50%, but they were at high risk of CEA based on physiologic and anatomic criteria. And it showed that there was only a 1.4% stroke rate at 30 days, which is lower than all of even the stenting trials. But the verdict is still out because it's a new procedure, and the longevity and durability of this procedure is still up in the air. So, and then of course, because it was like a safety trial, it had a lot of exclusion criteria, such as cardiac emboli in the last 72 hours, bleeding disorders, life expectancy less than 12 months. So there's a lot of different factors that kind of went into these numbers, but it is nice to know that it does have very low stroke rate. And then at Brown, I'm glad to see that I'm keeping everyone awake today. At Brown, our group looked at symptomatic carotid stenosis.
That's par for the course, by the way, Matt. Don't worry.
I'm sorry. At Brown, we looked at patients that had symptomatic disease, and we actually showed we had 63 patients, and we had really great results actually. So we only had 1 minor stroke. We had 0 disabling strokes. We had 1 NSTEMI. We had no STEMIs. We had 3 deaths, no cranial nerve injuries, 1 neck hematoma requiring washout, and 1 carotid dissection. And so this is, overall, this is a really good cohort. The 3 deaths, 2 of them were kind of CMO deaths, where one of them had a basal ganglia hemorrhage and was going to, have a fixed deficit. And I guess the family decided that they did not want to continue with care. It was kind of like they had some they were having some trouble weaning the vent as well. And then another patient died of trouble with gastroenteritis. And then another patient, we couldn't nail down exactly why they had expired, but we're still kind of looking into that now. But the results overall were really great, and this was for symptomatic disease. Other things to consider include gender. So we know that the risk of ipsilateral stroke in patient was lower in medically treated women than men. The perioperative risk of death was higher in women. For 70 to 99% stenosis, however, men and women had similar outcomes. So that was great. But we saw that with 50 to 69% stenosis, even when symptomatic, CEA was actually not beneficial. There was a trend towards benefit. So there likely are a proportion of women that have with high risk factor profiles that would benefit. But we need to find other ways to possibly treat these women with high risk with extracranial carotid artery stenosis. Race is another factor that plays into carotid revascularization. So non-white patients are 2 times more likely to have strokes after carotid stents than with carotid endarterectomy. They're also more likely to be treated at low volume hospitals, which is a risk factor for doing poorly from after a carotid revascularization procedure. And then non-white race is an independent risk factor for predicting an increase in 30-day stroke and death after revascularization. So again, for our patients that are Black, Hispanic patients, we need to be looking at ways to revascularize them that work best for them. So it may be better to offer a carotid endarterectomy for a patient for one of our Black patients that we think may have a stroke afterwards. Or there actually has been data to show that there are platelet receptors that are seen in Black patients that are not seen in white patients that actually cause platelet aggregation in the setting of dual antiplatelets. So finding drugs that would block these receptors could decrease the amount of strokes that patients are having, that our Black and Hispanic patients are having after carotid stenting. Timing is also something that's important. So we know from NASCAD and the European trials that carotid endarterectomy within 2 weeks of a TIA or non-disabling stroke improves outcomes. But observational studies have shown that recurrent stroke, that there's an increased risk of recurrent stroke with carotid endarterectomy within 48 hours. So it seems to be that the optimal timing for this would be 3 to 14 days after symptoms. Contralateral occlusion is another thing to consider. Medically treated, we know that revascularizing the carotid via stenting or carotid endarterectomy is better than medical treatment, but carotid stenting and TCAR are even better than carotid endarterectomy. So our patients that have contralateral occlusion should be getting referred for TCAR or stenting. So in wrapping up, the question is, when should we do what? So our patients that have, that are under, I don't think that we are ever going to get rid of or should get rid of carotid endarterectomy. And so patients that have favorable anatomy can't tolerate dual antiplatelets. They need anticoagulation in addition to dual antiplatelets. There's a heavily calcified lesion or even a carotid thrombus that is surgically accessible. Carotid endarterectomy is probably the best thing for them. And then again, when looking at our Black and brown patients, we may need to be offering them a carotid endarterectomy over a stenting, just given some of the data that we've seen. So this is actually a patient that we tried to treat with TCAR, but they had a heavily calcified plaque, which we thought we could get through and open up, and we were not able to get through. We took them to the OR for a we converted actually during the case to carotid endarterectomy, took out the plaque, and the patient did well. So clearly, carotid endarterectomy, while we do have these new tools, is still useful. Peripheral access stenting is also very useful. It's minimally invasive. It can be done under local anesthesia. So it's great for patients that can't tolerate general anesthesia. Access to distal lesions. So sometimes the plaque goes up too high for us to reach in carotid endarterectomy. And so that would be a patient that would benefit from a stent. It can be done acutely. So sometimes during a stroke, we have tandem lesions, which is essentially where you have either carotid occlusion or carotid stenosis, and then you also have a clot in the head, and so sometimes you'll have to place a stent acutely. And I'm not going to get into the controversy of when we should and shouldn't do that, but that it would be another kind of scenario for doing a stent. You don't have to clamp. So in a patient with isolated hemispheres, this may be a better option, even with our shunting technology. And then again, with patients with contralateral occlusion, carotid artery stenting and TCAR is probably is better. So the other thing to look at is the anatomy. So with our peripheral stenting, the type of arch that they have. So some anatomy is a bit unfavorable, and the arch can be hard to navigate. And so on the left is kind of a more favorable anatomy, and then on the right is a little bit less favorable. And so navigating the arch can be something that would steer you more toward, if you have an unfavorable anatomy, it steer you more towards doing a TCAR. So if you have an arch that you think would not necessarily be the best arch to navigate with your peripheral devices, then doing a TCAR is a great option for you. It's minimally invasive. You just do your cut down, as I stated earlier. It avoids major cranial nerves. Vagus is often encountered, but is usually not injured. There's no need to cross the lesion before you have distal protection. And so that's the other thing when we're doing our peripheral access, our peripheral stenting, you have to put up your distal protection device, and you have to cross the lesion before you actually have distal protection. And so in TCAR, that avoids that. And then again, sometimes it can be hard to navigate that through. And even if you get through, sometimes there can be loops that prevent you from getting high enough to with your distal protection device to place your stent. So that would be another reason to kind of do a TCAR. So with that is pretty much the end of my presentation, and I welcome any questions. But I want to thank all of my my faculty, both at Brown and University of Washington. I've learned a lot about the nuances of carotid revascularization, and I just want to thank you for all of that. And then with that, I will open up the floor to questions.
Well, thank you, Matt. Fantastic presentation for, a large topic, and obviously there's a lot to discuss here. And I think I'll just start the ball rolling with sort of one part of this is the differences in occlusion time for the various techniques. I think endarterectomy would have the longest occlusion time, and how TCAR fares in that compared to other endovascular techniques. And the other issue is you showed that picture or that video of the debris in the filter.
Mm-hmm.
And it always amazes me, that whenever you do carotid stenting in the traditional sort of anterograde femoral or radial access, there's almost always nothing in the filter it's the rare case where you actually find anything resembling debris. So is there something about TCAR that, might trigger debris dislodgement or what have you, versus, sort of distal protection device with outflow reversal?
Yeah, so I think a couple of things. I think in terms of the speed of the operation, I think in terms of clamping down on the carotid artery, fairly quick. So usually it's, with less than 15 minutes of clamp time is usually kind of our like our average, and usually it's even less than that. And even during when we're clamping the carotid artery, we have there's flow reversal, we have SCCPs. Sometimes there are changes, and we can go really quickly and come off of the flow reversal. And that's kind of another thing that is helpful. In terms of the debris, I'm not sure. I do think that there's still some amount of debris that's getting through the distal protection device, and even our peripheral stents when we put up our EPDs. But I don't know if it's just that there's higher flow reversal, and then the filters are just better at picking up the debris, or what it might be. But we always find a lot of debris in in that filter, and so I'm not actually sure why there's more in this than there are with the embolic protection device. But I'm hoping that it's because we get more of the debris than we would in the peripheral stenting, but I'm not sure exactly why. That's a great question, though.
Other questions from the audience, please?
Yeah, great presentation, man. I appreciate it. It's a big topic to tackle, and you did it well. I think the two questions I have for you, you can choose one or both to answer.
Sure.
So number one is what is the state of the science of revascularizing asymptomatic carotid stenosis? Because the guidelines still say it's reasonable to consider for, based on the ACST trials and others, or the ACAS trials, but a lot of the modern data really suggests that we're on pretty shaky ground with the medical management being what it is. So in what cases would you consider, or would you ever consider, revascularizing an asymptomatic carotid stenosis? Let's start with that question.
So yeah, I agree. I mean, I think there are there's a lot of data showing that in asymptomatic disease, it is medical treatment is just as good. And so I think patients that have ulcerated plaques, I think that is a high risk feature that I think should be revascularized. And then I think even with medical therapy, if there is a continued stenosis, like if the stenosis continues to get worse over time, as not just one time point, but if it continues to get worse over time, I think that would be another reason to consider doing some type of carotid revascularization. But I think specifically in patients with an ulcerated plaque, that's just a high risk feature that I would be worried would kind of cause some type of stroke in the future. And those things I think need to be teased out in some of these newer trials, as we're realizing that medical therapy is doing so great.
Yeah, thanks for that. And I agree. I mean, I think the issue is that we know that it benefits some. We're just bad at picking who it benefits, right?
Right.
That, we know that patients are asymptomatic with carotid stenosis until they are symptomatic.
Right.
But the data, especially the modern, pretty large observational data, especially the relatively recent VA study, really showed that they're if you redid the ACAS trial today, you might not find a benefit at all.
Right.
Which is a little bit scary. So I think it's hard to pick these winners. And then the other thing I was going to ask you is, when you see your average patient, you talked about a lot of different factors of race and sex and timing and all that. What do you reach for first? What will you reach for first in your practice when you see your average patient post-symptomatic symptomatic carotid stenosis within that 3 to 14-day time window? What do you reach for first? What's your preference?
I think, in terms of like preference, I think the biggest thing to consider is what is the best in your own hands, because we know that even so say you do carotid endarterectomies and your complication rate is 4%, you may not necessarily be the best, that may not be the best procedure for them, but a TCAR is 1%. So I think, every surgeon should have this in their armamentarium, but they should also look at what is best in their hands, because we know that the surgeon's ability to do the procedure well is a big factor in the carotid revascularization techniques. I think with my training, I would probably favor TCAR, if, kind of all things being considered. But, I think with, as I go into practice, having those other procedures and abilities to do the procedures, I think are really important, especially because for patients that are not able to undergo anesthesia, for whatever reason, I do think that peripheral stenting is still better even than TCAR, because TCAR, you still have to do this under general anesthesia. And then again, for my Black and brown patients, I do think that carotid endarterectomy is better for them. And so I would have to kind of see how they fare in my hands, So I think, that the surgeon's preference, it should be based on which procedure they can do the best, with the least amount of complications. So
Wise answer. Thank you.
Yeah, I'd like to make a comment. When you said the complication rate is 3%, 4%, whatever percent, it's a percent of 100.
mm-hmm.
The problem is that there is initially a learning curve, and no surgeon reaches that. Obviously, how do you get there is a question for any procedure, really. So initially, of course, you do it with mentors and experts, but then you start doing procedures on your own. For the young people, you need to start with cases where the risk is low. I'm just let's say, only talking about either carotid endarterectomy, which is a complex surgical procedure in itself, or TCAR, which is a more modern or more recent procedure. The problem is that you need to get there, and I think that the learning curve is important, and I'm afraid the learning curve doesn't become established until a certain number, whatever that number is. I would say for carotid endarterectomy, perhaps the learning curve is about the first 50 cases. And where do you do 50 cases? This is very always a tricky question. In which practice do you do 50 cases within 2 years? So this is perhaps an important question for you as a young person, relatively young, starting out, going to practice.
Yeah, I think that just kind of speaks to in training you do a lot, but then also, as you're going out into practice and you're kind of getting, your actual hands together, I think that it's important to have, really good partners that, can mentor you through your first few cases and get you really confident, and then so that you can do your own. It's also important to note that, if I'm not doing a lot of carotid vascularization procedures in my practice, it actually is worse for the patient. So, going to a center that does a lot of carotid revascularizations is important, when doing this. So, to your point, being able to do a lot of these procedures, both in residency and in early practice, is kind of where you do that. And if you're not doing that, you may not actually be doing a great service to your patients. Even though you're trying to kind of learn this procedure, if you're only doing a few a year, then it may not actually be something that you should keep in your toolbox, and you should refer to other people that are doing that at a higher volume center that are able to do it in a safer manner.
To that regard, can I make a comment that I don't know if Rich is on, but there are many residency training programs around the country that have shifted so far to the endovascular that they're doing very few carotid endarterectomies. And I don't know if Rich is there, I'd like his comments, but I don't know how to address this. If an institution is not teaching residents carotid endarterectomy, and then they want to use that as part of their armamentarium for treating carotid revascularization, how do you deal with a problem like that?
Well, I just, I let the Rich isn't on the call, but I think from a cerebrovascular standpoint, there's no question that neurosurgery in general has sort of lost the battle of owning carotid endarterectomies in many communities across the country. It's the rare neurosurgical center that is dominating that market. Um, and As a result, the programs and the RRC has sort of conflated carotid endarterectomy with other carotid procedures just so that programs could meet the minimums, and they've dropped the number to like 10 or some extremely low number like that per resident, for over 7 years, which by no means qualifies them at all to do that operation. The point is well taken, but I think that the practice forces, the market forces that govern this relatively small number of patients per community is overwhelmingly toward vascular surgery, overwhelmingly toward endovascular treatment. And we had hoped that carotid endarterectomy would make a revival with some of the newer data over the last 10 years about early carotid endarterectomy as the preferred and better method of treating symptomatic patients, stroke patients. But again, the distribution of those cases is relatively similar across the specialties. So I think that the ship has sailed on that mark, and fewer and fewer generalists are comfortable doing endarterectomy. I would argue that no recent graduates who aren't cerebrovascularly trained would ever do a carotid endarterectomy. Probably 99% of graduates. So we're really we really sort of given up that, much like certain aspects of peripheral nerve and other things. We've pretty much given up the specialty.
The situation is just the opposite of what it was in the 1990s when carotid stenting was becoming available, and organized neurosurgery took it upon itself to basically say, no, this is part of our training program. We need to get our residents into the interventional suites, and it's a ACGME requirement, and there was enough pressure of doing that to really start the ball rolling to endovascular training. And I'm just wondering if it should go the other way now with organized neurosurgery saying this is part of our training, and our residents have to get into the OR with vascular surgeons if they don't have neurosurgeons doing it in their program.
No, I agree. Funny thing though is that being a dual trained vascular surgeon generally helps you in terms of building your practice. Like if you treat aneurysms or AVMs or what have you. But it seems that the carotid stenosis market doesn't seem to favor people with all the tools in the toolbox. They have very ingrained, referral patterns that have been hard to break. Mike Levitt's done a great job, revitalizing our carotid endarterectomy program, but he's generating a lot of the cases from the stroke patients that come in with acute strokes, and those used to go to our vascular surgeons. In terms of really, compared to the community, obviously we're still a minority of the marketplace. So I hear you loud and clear. We need to decide in a very programmatic way, strategic way, if we really want to, maintain this skill set. But it's becoming more and more the bastion of fellows and super specialists in cerebrovascular. So good point.
But one of the things I want to emphasize is that also our residents get more experience with simply the exposure of the carotid arteries in the neck, because we do a number of exposures for a variety of other cases where you have a lesion, tumor in the cavernous sinus or something like that. So we have more cases in which we actually expose and dissect not just the common but the internal external carotid artery. This has to be added or has to be considered in addition to the endarterectomy, because a lot of the work of the endarterectomy is just simply the exposure without damaging the surrounding structures. I was used to think of the carotid endarterectomy procedure as an elitist operation, in the sense that you put in a lot of effort. The number of RVUs are not that great, and then the potential of complications is relatively high. And the operation sometimes can go perfectly, and then you have a problem with stroke. And in fact, same can be said for carotid stenting. So I think that just being familiar with the anatomy of the area, even in our lab and in the OR, is equally important.
Matt, it sounds like various treatment modalities have a particular subspecialty interest. So, like, TCAR is a real favorite among vascular surgeons because they're used to doing cut downs for everything, and working in such small, short distances like that. But, how do the radiologists manage TCAR with the cut down piece? How does that operationalize?
So the radiologists actually never, at least at Brown, they never did it. It was all neurosurgeons that did it. So we have a really like big stroke population, and we were also referred all of the carotids from that. And so all of our carotids were done basically through that referral, and the neurosurgeons did it. The vascular surgeons, that there was like a big kind of kerfuffle, I guess, with the vascular surgeons, because they thought that we were taking all their cases. But yeah, so the neurosurgeons do it. The radiologists don't do any of the TCAR portion. So it's just neurosurgeons.
And then I don't know if you guys ever did the MoMA technique. We didn't, but it was somewhat had its day in the sun, where it's a double balloon catheter with proximal and distal occlusion into the ECA. So flow reversal using balloons, and
Right.
not the complexity of TCAR with the reversal of flow into the femoral artery. But that is sort of, I mean, correct me if I'm wrong, faculty out there who are more specialized in this, but like it sort of has fallen off the wagon. It's not really hitting the tipping point, other than a few, sort of tip of the spear type centers like Buffalo that do a lot of carotids. And so it hasn't quite caught on, and it's a very similar technique to existing paradigms, which is transfemoral or transradial, and anterograde sort of treatments with distal protection devices and whatnot. Well, what will allow TCAR to succeed where things like MoMA failed?
I think what will allow TCAR to succeed is one. I think that the ease of TCAR, and I think that there actually is there is a lower almost stroke rate, and so I think when people see that is true, then people will adopt it more. Like I said, the procedure is usually like you're in and out of the room within an hour. So I think that also is something that is really beneficial, especially for our patients. Even when you're doing these, you're putting our patients under general anesthesia. The decreased amount of time in the OR, I think, is helpful for these patients, because they are super sick already at baseline. So and then I think with the hybrid rooms that are being developed around the country, I think that that's like another use of the hybrid room, because we didn't have a hybrid room, so we used this like really old portable angio. And so being able to do this procedure in a hybrid room is another kind of great use for a TCAR. So I think those are kind of three main things that would cause it to become more in favor.
Well, thank you, Matt. Great presentation. I think you've enlightened all of us, from those who do this for a living and those who don't. And so I appreciate your expertise in shining a light on TCAR for us. And again, thanks for all your work this year.
Thank you. You guys have a nice day.
All right.
All right.
Thank you, everybody.